Hello, my name's Dr. Karl Landorf, and I'm a Senior Lecturer and Research Coordinator within the Department of Podiatry. Today, for your podiatric assessment and management, we'll be looking at describing lesions on X-rays and other imaging modalities, but in particular X-rays. Importantly, some of these principles that I'll go through today do cross over to some of the other medical imaging modalities such as CT scans and MRIs, but today will be predominantly focused on plain film X-rays. So why is it important to be able to describe a lesion? I guess the most obvious one is from a medico-legal perspective, that if you haven't described it appropriately or haven't detected something appropriately, quite simply you could be sued for that. But we also have a responsibility within our profession, and I guess within the broader medical community, to be able to take notes on various conditions and to be able to describe to our colleagues what we're seeing. And I always tell the students a very simple, or give them a very simple scenario. And the scenario is that if you're a practitioner in Melbourne and you've got a very interesting case and you've got X-rays on the person, you should be able to pick up the phone to a colleague of yours in Perth and describe what you're seeing on the X-rays well enough that that person in Perth can picture exactly what you're talking about. They may not know the diagnosis, but they should be able to picture exactly what you're talking about. So that's the exact location, the exact appearance, and the exact radiographic terms, or using the most appropriate radiographic terms. So that's what we're endeavouring to do. There's some very simple rules to be able to achieve that, and we'll now start going through those. Firstly, I need to acknowledge Adam Morrow, who assisted with some of the development of this lecture, and particularly assisted with some of the diagrams to help explain some of the terms. So we'll be going through today 5 quite simple sections. Firstly, it's how to describe the projection that you're seeing the lesion on, the side, simply left or right, the location within a bone or soft tissue, the radiological descriptions, and there might be some other descriptors that are quite specific to different pathologies or different disorders that you might need to use. So that's what we'll be going through today. So firstly, the projection. You need to state the projection that the lesion is visible in. For example, it might be in the lateral projection. Now, just if someone's got a lesion, and let's for example say it's a lesion within bone, and it might be a benign bone tumour, for example, it may well be present in one projection, but not in another. So it might be, as the example states here, you might be able to view it in the lateral projection, but you can't view it in an AP projection. And it might just be there might be other bones overlying the bone that you're looking at with this lesion. So that's important because that obviously leads the person reading your notes to the exact projection that you see the lesion on. Stating the projection is not necessary if the lesion is obvious on all projections. However, if you're making a point of a particular feature of the lesion, then you should refer to the projection that you can see that particular feature in. Okay, so we obviously need to state the projection or projections that the lesion is seen in. The next issue we need to consider is the side, and you need to state the side that the lesion is present, for example, the right foot or the left foot. Now, that seems blindingly obvious, but you will be surprised how many people won't do this. So just assume that the person reading the notes will know. It's obviously not needed if you only have one side of x-rays. So if you only have the right foot, then you obviously don't need to state the side. You may only have one side if there's an obvious fracture, or if you have recent films of the other side. Most of the time in podiatry, we do actually order bilateral x-rays of both the left and right foot. But it could be that you ordered bilateral x-rays of a patient of yours only a month ago, and now they've come in with a new injury. They might have turned over on their ankle and you're suspecting that they could have a fractured bone. Well, it would be silly to get films of the unaffected side, given that you've already got films of the unaffected side from only 4 weeks ago. If there was maybe a 2 or 3 year gap, then you may want to consider getting both sides done again, because obviously things can change. The next issue is the location, and this is critically important to be able to describe this well. You need to be able to state the exact location of the lesion in the bone or the soft tissue, and that is which bone and what area of bone. You can't just say there's a lesion in the forefoot or there's a lesion in the rear foot. You need to be able to say exactly which bone it is and exactly what area of the bone using the most appropriate anatomical terminology. Now, you may also need further information. For example, you might need to indicate that it's in the cortex or it's in the medullary canal. If it's related to a joint, you might need to say it's intra-articular, i.e. within the joint, extra-articular, outside of the joint, juxta-articular, which is either side of the joint, periarticular, which is around the joint margin somewhere, and subchondral, which is just under the articular cartilage. These terms will be able to give the reader of your notes or your report a very accurate description of where to look for the lesion. So just stating that again, going back to that first point, you need to state the exact location of the lesion in the bone or soft tissue, which bone and what area of bone, or which area of soft tissue, and you might need further information. For example, if it's in the bone, you might need to say it's exactly in the cortex, the hard cortical bone, for example in the shaft of a metatarsal, or in the medullary canal, where you have the softer cancellous bone. And if it's around a joint somewhere, then you might want to use intra-articular, extra-articular, juxta-articular, periarticular, subchondral, all describe exact locations relative to a joint. So giving you some examples of location, these might be some examples you would use. So the first example is in the distal metaphyseal region of the third metatarsal. So that description is very simple, but it's using the appropriate terminology, and it describes exactly the region of a specific bone. So in the distal metaphyseal region of the third metatarsal. Now you obviously need to know your bone anatomy to be able to do this effectively. Let's go for another example. In the anteromedial aspect of the body of the calcaneus. So again, talking about a specific bone, the calcaneus, and now we know to look at the anteromedial aspect of the body of the calcaneus. So very, very specific location. If you just said the calcaneus, or the front of the calcaneus, it's not good enough. It's not giving an exact location. Third example, in the periarticular soft tissue around the interphalangeal joint of the hallux. Periarticular meaning around or surrounding a joint. So we're talking about the soft tissue surrounding a joint, and that joint is the interphalangeal joint of the hallux. So again, if I can bring up the scenario of you being on the phone to a colleague in Perth, then if you were reading this out over the phone, describing the x-rays that were in front of you, your colleague should be able to picture this really, really clearly. And I'm hoping you can see that those three examples provide an exact location for that person, so they should be able to picture that in their mind easily. The fourth point is radiological description, and those first 3 points are obviously fairly obvious. Now we're using some of our radiological describing terms. So we use the radiological terminology to describe the lesion, and this is terminology that you have either gone through before or you will go through in a more formal format, such as a lecture or workshop format. So these terms are either increased density or decreased density, and you can use the terms radioopaque or radiolucent. So radioopaque for increased density or radiolucent for decreased density. The next terms are sclerotic and ebenation. So sclerotic meaning increased density over and above what should be there. And ebenation really is just the end stage of sclerosis, meaning that you have really, really increased density and it's not going to get any worse. Osteoporosis and resorption. So osteoporosis is a area of decreased density, and it's usually an area of decreased density signified by a lack of ossified trabecula that would normally be there. Resorption is obviously resorption of bone, where the bone is resorbed and you get an area of decreased density. Calcification or ossification, dysplasia or dystrophy, and lipping or spurring are all radiological describing terms. As I said, you will receive exact definitions for these in your other more formal sessions. So these terms can be used to describe areas of bone. Giving you some examples of description. So you could, for example, say there is an area of increased density. There is a radiolucent lesion with a sclerotic border. So radiolucent lesion meaning there's a lesion that has decreased density or radiolucency, but in this example we're saying it has a sclerotic border, so it has an area of increased density over and above normal around the border of the lesion. Another example, there are periarticular erosions. So this means there are erosions around the joint that you're concerned with. And let's just say it might be the first metatarsophalangeal joint. So what you're seeing is small erosions or small punched out areas around the joint margin. There is juxta-articular osteoporosis. So juxta-articular means either side of the joint. So it means the bone either side of the joint is showing osteoporosis or decreased density. And the final example is there is osteophytic lipping, and that usually relates to a joint. Or sorry, I should say it does relate to a joint. And this means that you're getting small bony lips around the joint margin. So you're getting little bony outgrowths on the joint margin. Now, by using terminology like this, you're being very, very specific, and a person who, again, is reading your report should be able to picture this really clearly. You need to be able to use this terminology to enable either another podiatrist or another health professional to understand exactly what you're talking about. To do that, you need to use the most appropriate term at the appropriate time. You can't just say there's a dark area or a light area, or there's bits missing around a joint, or there's some fuzziness underneath the joint, or some lumpy bits here or there. That's just not good enough. If you think of it in terms of medico-legal, if your report and you ended up in a court of law, a lawyer would have an absolute field day with you if you hadn't used this appropriate terminology. So it's highly important to protect yourself from a selfish perspective, but also to do the best for the patient, so everyone knows exactly what you've found on the x-rays. So just doing a summary thus far, we've been through the projection. So you state which projection you can see the lesion in. We've been through the side, it's the left side or the right side. We've been through the location, and we're talking about which bone or what part of the soft tissue and the exact location within that bone or soft tissue. And we've just covered off the radiological descriptions or radiological describing words that you would use, which we've covered in other sessions. Now there might actually be some other descriptors that you might need to use in specific circumstances, and we need to go through some of those. I've just brought up some text on the right there in yellow, and you do need to think initially in terms of this rational sequence. So you start from very simple descriptions and you go to more complex ones. Obviously, stating the projection and which foot it is the very simple stuff, and the radiological describing becomes more complex. So we need to think initially in terms of this rational sequence. However, in reality, it's not necessarily in this order. You may actually reverse the order and describe from point 4 or issue 4 to point 1, and then include 5 if needed. For example, if we actually used a description, then we might actually use the radiological description first. So we might say there is an area of decreased density, and then we might go to location in the proximal diaphysis of the left fifth metatarsal. So we've said the side as well, and then finally we can say in the AP projection or something like that. But what I'd suggest that you do initially is just think in terms of this logical sequence to begin with, so you don't miss anything. And then you tick off things with any other descriptors that you need for a specific circumstance. So putting points 1 to 4 together before we go on to these other descriptors, I'll give you some examples. So first example, there is a radio-opaque lesion in the neck of the third metatarsal of the right foot. Okay, now we might also want to have on the AP projection there or something like that. So it's very clear the exact location of the bone and exactly what we're looking at, a radio-opaque lesion, meaning a lesion that has increased density. Another example, there is a bony spur on the plantar aspect of the left calcaneus, and that would probably be on the lateral projection. So we can see here in this example, we know the exact location and we know there's a bony spur there. Third example, there is subchondral sclerosis either side of the proximal interphalangeal joint of the right second toe. So again, we're being really precise about where this is, and we're seeing subchondral sclerosis, which means increased density over and above normal, just below the subchondral region or the articular cartilage chondral region. Final example, there is a dysplastic lesion in the distal metaphyseal region of the right fibula. So again, we're being very specific about the location, distal metaphyseal region of the right fibula, and we're saying that there's some form of dysplasia there, which is a localized area of altered metabolism in the bone. And for example, it may well be a bone tumour. So there is a dysplastic lesion in the distal metaphyseal region of the right fibula. So again, if we think back to that colleague in Perth, they should be able to picture this really clearly. Now we're going to tick off some of the other descriptors that you might use in very specific circumstances. There are 6 we'll go through, and they are size of the lesion, shape of the lesion, margination, so what's happening to the margins of the lesion, and that can be very, very important in telling you whether the lesion is fairly benign and slow growing or whether it's aggressive and fast growing. The cortical integrity, i.e. the integrity of the cortical bone, the behaviour of the lesion, and if there's any periosteal response. So we'll go through each one of these in detail now. The first one is the size, so essentially you just measure the lesion on the X-ray. If it's a longitudinal lesion, you give the length and width, for example 3 centimetres long by 1 centimetre wide. If it's just a round lesion, then you just give a diameter. For example, if it was a round lesion, you might just say it's 1 centimetre in diameter. Now this allows comparison of films on different dates. So for example, if you did have a bone tumour or a soft tissue tumour, you can actually measure the growth of the lesion, whether it's increasing or decreasing. And remember, if the X-rays have been taken appropriately by the radiographer, there shouldn't be any magnification, so there should be no change, relatively speaking, between an X-ray taken in 1 week compared to an X-ray taken on another week or another time. The shape, and you use just very simple descriptions. Is it round? Is it oval? Is it elongated? Is it geographic? And if you think in terms of the outline of a country there, so geographic lesion just means something that I guess has not a linear shape at all. And if we think in terms of Australia or Tasmania, that's a geographic shape. It's got sort of lumps and bumps to it, rather than being a nice linear shape like a round or oval shape. The next descriptors relate to margination, and as I said, this is very, very important, and I'll talk about this as we go along. There are basically 2 broad categories. There's imperceptible margination, and that's when there's a poor, hazy, or ill-defined margin on the lesion, and that's often called the zone of transition. Now, a poor, hazy, or ill-defined margin indicates an aggressive bone, or indicates aggressive bone destruction. What we like to see is a really nice, even margin, or a sharp margin. And this is where there's clearly identified interface between the lesion and normal surrounding bone. And this is indicative of a slow-growing lesion. And obviously, if you think in terms of tumours, you'd much prefer to have a slow growing lesion, which is generally benign, compared to an aggressive lesion, as indicated in that first one on imperceptible margination. Now, this is it's not completely intuitive, this, because often when people see a sharp margin to a lesion, the lesion stands out more and it looks worse to the untrained eye. Whereas a lesion that has an imperceptible margin, which is poorly defined, hazy, tends to not look as bad. But the reality is quite different. The reality indicates that if you have an imperceptible margin, poor, hazy, ill-defined, then it's indicative of a aggressive bone destruction, and that's not a good sign. In contrast, if we have a nice, clear, sharp margin, it usually indicates that the lesion is well encapsulated and it's not doing anything quickly, which is a good thing. Now, these photographs or these X-rays aren't particularly clear, but you can also look at this diagram here, which is essentially a sort of a cutaway femur. So this is a femur here, and the lesion is actually sitting in there in the diaphysis or the shaft of the femur. And what we can see is we can see some decreased density in here, but we can't really tell where it starts and where it stops. So it's actually got an imperceptible margin. It's poorly defined and it's a bit hazy. The diagram here, if you can see the hatching within the red area, if you can see the hatching, it's sort of, again, you can't really see where that hatching starts or stops. Don't think so much about the red outline, but think about the hatching here. You really can't see, there's no clearly defined border indicating exactly where that lesion sort of starts and stops in there, and we can see that there. In contrast, sharp margination, and if we look at the diagrammatic cutaway here of the femur, so just to explain this, that would be the cortical bone surrounding the femur, and this section in here is the cancellous or medullary bone. But if we look at the lesion now, and we look at the hatching, or the cross strokes on that, we can see that there is basically either the lesion or there's no lesion. So we have a clearly defined border. And if we look at this example again, we can see this clearly defined border to this lesion. Okay, so it's just much easier to see and to see the defined borders of it. So in reality, this lesion is probably a better lesion to have than the previous example. And I'll go back to the previous example. So this one's probably worse, even though it actually looks better to the untrained eye compared to, and I'll go forward a slide, compared to this one. So sharp margination is generally a better sign than imperceptible margination. It's very, very important if you have bone tumours, because the really aggressive bone tumours, such as osteosarcomas or Ewing sarcomas, generally have this imperceptible margin. That means they're highly aggressive, they're growing really quickly. The next issue we're going to discuss is cortical integrity, and this just basically relates to what's happening to the cortex. Is there cortical thinning? Is there cortical thickening? Is there expansion of the cortex, destruction of the cortex, or is there a fracture there through the cortex? Okay. Now, some conditions can be identified by whether the cortex has become thickened or thinned, for example. So this again is really useful information for getting an exact diagnosis. The fifth issue we're going to cover is the behaviour of the lesion, and this kind of relates to what the lesion looks like. And essentially there are osteolytic lesions which show up as decreased density, and that might be geographic, so it might be shaped like a country. It could be moth-eaten, which will have all little holes through it, well, that's the appearance of it. Or it could be permeative lesion, which kind of looks like a sponge. And secondly, there are osteoblastic lesions, which are essentially the opposite to osteolytic lesions, and they show up as increased density. So we have osteolytic lesions, which have decreased density, and osteoblastic lesions, which have increased density. And if you remember just terminology, if you remember back to your pathology, lysis, for example, lysis of a cell, of a body cell, means destruction of the cell. So things are actually decreasing. The cell will no longer be there because it's destroyed. So osteolytic lesions, osteoblastic lesions. Sometimes you can actually get mixed lesions where there is some osteolysis and some osteoblastic activity within the lesion. Okay, so we'll just go through again some of these describing terms. This would be a geographic lesion, so we can see it's not a nice even lesion. It's got sort of lumps and bumps, and the outer edge of the lesion isn't particularly linear. That for all intents and purposes is it's going to have jagged bits, lumpy bits, etc. So it's not a nice smooth lesion. A moth-eaten lesion is exactly what the term describes. It looks as though some moths have got into the bone and basically gnawed away some of the bone. So you have this these areas of decreased density where the lesion has actually started to sort of destroy the bone, indicated there on the diagram. The red areas are the moth-eaten areas, and the black or grey areas are just trying to sort of demonstrate what the normal cancellous bone would look like, which has little holes in it normally, but the red area is the moth-eaten part in this particular example. A permeative lesion is similar to a moth-eaten lesion, but it's just a bit more widespread and doesn't look quite as neat, I guess, as what a moth-eaten lesion would look like. So we can see the example here. There's sort of much wider destruction, and some of the holes are quite large, some of the holes are smaller, whereas the moth-eaten tends to be sort of more small, sort of, I guess, even-sized holes. Permeative lesion can be much greater bone destruction in some areas. Okay, the final issue we want to tick off today is the periosteal reaction, and again, this is a highly important indicator of certain bone lesions, particularly tumours, fractures, and for infection of bone. This is really important. Just expanding on that last issue of infection and bone, if you start to see periosteal reaction with an infection, it usually means that the bone has been infected and the periosteum is starting to react to that infection. Bone infections are generally very hard to eradicate or get rid of, so it's obviously not a good sign to see that if it's advanced, if the infection has advanced into the bone. There are three basic patterns to periosteal reaction, and I'll give you diagrammatic examples of this in a minute. There's the solid response, the laminated response, and the spiculated response. And there's two other patterns, and they are referred to as the sunburst response, which is similar to the spiculated response above. So the sunburst is similar to this, but I'll show you pictures of this now. And another one which is Codman's triangle. So you get this triangular shaped appearance of the periosteum. Okay, the best way to describe these is to actually look at some pictures of them. But before we do that, I'll just give you a little bit more information about each one and then show you the picture. So a solid response usually relates to a slow form of periosteal irritation, such as a slow-growing tumour, stress fracture, or venous stasis, where you have venous insufficiency in the venous vascular system. So usually it's not too much to worry about compared to some of the other periosteal responses. This would be an example of a periosteal reaction that you would refer to as a solid response. So the red is indicating the periosteum, which is the lining surrounding the bone. There's been some sort of irritation under here, and we don't know exactly what it is. It might be a stress fracture. And basically the periosteum just gets lifted up. So essentially there's either inflammation or blood, for example, forming under there, and the periosteum, represented by the red, just basically lifts up off the bone in a solid periosteal response. If we look at the example over here, this is most likely to be a stress fracture of the proximal tibia, and the stress fracture might be positioned across here somewhere, and we can see this lump of periosteum has lifted up here, and it looks like it's starting to actually calcify now, which would mean that the person would actually have a palpable lump in that particular area. Just a reminder, this is the fibula here, and we can see a growth plate here. So this is in an adolescent. The growth plate's almost closed, and we can kind of just see a very slightly open growth plate in the proximal tibia there, and the knee would be just up above that. So that's a solid periosteal response. Just an example of a solid response. So the lesions within the bone, and usually you just get some sort of solid periosteal reaction. So you get a little bit of lifting of the periosteum above that. So sorry, this is just a series. So we get the lesion gets bigger again, and then now it's starting to affect the cortex and the periosteum, and just enlarges out like that. So I'll just go through that little sequence again for you. So we have a lesion forming, getting larger. It starts to affect the cortex, and the periosteum starts to get lifted up until we get a solid periosteal response, and an even larger one. And obviously that would be quite palpable. Okay, the next one's the laminated periosteal response, and this is where you get alternating layers of lucent and opaque densities. And this is classically associated with Ewing's sarcoma, which is a malignant bone tumour. Now, when I say alternating layers of lucent and opaque densities, the best way of describing this is if you cut an onion in half and look at the layers of the onion, that's very similar to the appearance of the laminated periosteal response. So lamination just means you get one layer on top of the other, and you'll have quite distinct separation between those layers. So you get alternating layers of lucent and opaque densities. Now this obviously isn't a particularly good sign if you see this, because it usually is associated with malignant tumours. So this is the appearance. If we look at the red periosteal response over here, we can see the layering here, which is similar to the insides of an onion and the layers of the onion. If we look over here, what we can see is a widespread lesion within the tibia. We can see that it has imperceptible margins. It's very hard to pick where this thing starts and where it stops. And then when we look over here, it's a little bit hard to see. This isn't a great X-ray, but it serves the purpose just to show you. Then there's actually layering within this, within the actual periosteal response, similar to here. So it actually looks sort of like a cut onion, and you're getting that layering effect. Sorry, I'm just going to go back one. We can also see that this is obviously in a child, possibly going into teenage years. The growth plates are still open, but they are closing up. So they're the distal growth plates in the fibula and within the tibia. So this would be a highly aggressive tumour. This one, it's widespread, imperceptible margins, and now we have this layered periosteal response, and that is probably a Ewing sarcoma of the distal, mid to distal tibia. The spiculated response is where you get fine linear spiculations or spicules, which are like fine linear hairs. That's what the appearance is, and they are orientated away from the cortex. Again, this is associated with aggressive bone tumours, for example, osteosarcomas, which are a highly aggressive bone tumour. So again, if you see a spiculated response, it's not a particularly good sign. So this is what you get. You get these sort of fine finger-like spiculations coming out of the cortex, and it's a little bit hard to see here. You can probably see it in this region a bit better. So you end up sort of getting these sort of like hairs coming out of the bone itself. And again, this is just a form of periosteal irritation from the underlying lesion within the bone. So this person probably has, I don't know for certain, but they probably have an osteosarcoma, and it's causing this spiculated periosteal response. Again, not a good sign. The sunburst response is similar to the spiculated response, but it just forms sort of in a fan-like fashion, so it's same as the spiculated, but orientated in a radiating or fan-like fashion. So this is the example. So it looks very similar, but it's just more fanned out, radiating, rather than the spicules just coming straight out. What's happening here at the margins is it's sort of fanning out like that. It's a little bit easier to see on a good quality X-ray. These are obviously just pictures, and it's a little bit easier to see the individual spicules in the spiculated response, or the sunburst response. So just diagrammatically, this is what a sunburst response might look like. So the lesion sets up and starts to grow, and gets to a stage where it starts to irritate the periosteum or affect the periosteum, and then what happens is you start to get these spicules forming in a sunburst fashion. I'm just going to go back one slide. So now we're getting this sunburst spiculated response here, and it's sunburst response because it's in a radiating fashion. Okay, the final one is Codman's triangle, and basically it's the same thing, but you get a triangular shaped response. This really is a non-specific finding. We can't isolate this to one particular condition, for example, one particular tumour. So it is a non-specific finding, but podiatrists deal a lot with diabetic foot ulcers and diabetic foot infection. If you get infection of the bone, then sometimes, reasonably frequently, you will see a Codman's triangle occurring as the infection starts to affect the bone. So this is what happens. We can see on the diagram here, this is just representing the cortical bone. In the middle here we have the cancellous bone and the cortical bone on the other side of the shaft. And what's happening is the infection, we'll just use infection as the example, or the lesion, is now eating into the cortex. The periosteum's being eaten away, and the periosteum's getting lifted as the inflammation or infection sort of tracking back. The periosteum just gets lifted up into this triangular shaped appearance, and we can see it really nicely on this particular picture. So the infection would be up in here, and we've got a Codman's triangle periosteal response either side of the shaft. So it's basically it's like surrounding. It's like a cuff or a sock surrounding the shaft of the bone there. And if you like, and this isn't particularly pleasant to think about, but if you like to think about it in terms of that the sock is just getting full of infected material or pus, so it's just sort of getting pushed away from the actual cortical bone, whereas down here the periosteum is still attached to the cortex of the bone. In here is just infective material, and basically that's surrounding the bone now. Remember, that's not absolutely specific to bone infection. It can be other lesions, but probably the most likely time that you will see it in clinical practice is with bone infection, particularly diabetic foot ulcers leading to bone infection. So Codman's triangle, just the diagrammatic representation. We can see the lesion being set up there and pushing, and basically the periosteum breaks, but it's still attached at one end, so it just gets pushed up into a triangular shape indicated there. Okay, so in summary, we need to accurately describe lesions so other health professionals understand what we're talking about and, importantly, can picture what we're talking about. So that's an incredibly important day-to-day role of being a health professional, is that you write really good patient notes, and other health professionals can understand what you're describing or what you're seeing, in this case on the x-rays. You need to describe in a rational order. So think about those 5 steps in describing lesions, and you need to stick to that rational order so you don't miss anything. And importantly, we need to use accepted common language. So we absolutely have to use the most appropriate terminology at the appropriate time, so other health professionals can understand what we're saying, and also if a case goes to the courts and there's a legal case brought against you, then you obviously need to have the backup of good notes, good descriptions of what you've done and what you've seen. Okay, and I think that's it. Oh yes, the final point is just the medico-legal point. And I think everyone obviously wants to stay out of the courts, but if we do ever go there, and if you are sued or a case is brought against you, then you obviously want to be backed up by using appropriate terminology. Okay, so that's it, and hopefully you'll get to start practicing this terminology with real X-rays very, very soon. Thank you very much.